There's a conversation most men never have with their doctor. Not because the doctor doesn't know the answer, but because most men never ask the question. And by the time they do, years have already passed. Years of quietly wondering why something that once felt effortless now feels uncertain. Why mornings that used to start with energy now feel different. Why a part of their identity they never had to think about has started requiring effort, attention, and sometimes apology. This video isn't about shame. It isn't about selling you something. It's about understanding what is actually happening inside the male body after 50, physiologically, hormonally, vascularly, and why the solutions that actually work look nothing like what most men expect. If you've ever searched for answers about erectile health, testosterone decline, or sexual performance after 50, or if you're someone who loves a man navigating these questions, stay with this, because what you're about to understand changes the conversation entirely. Let's start with a number that most men don't know. According to research published in the Journal of Sexual Medicine, approximately 52% of men between the ages of 40 and 70 experience some degree of erectile dysfunction. That's not a fringe statistic. That's the majority. And yet the silence around this topic remains almost total. Men don't talk about it at dinner. They don't up at the gym. They don't always bring it up with their partners. And so the experience of declining erectile function gets treated as a private failure, when in reality it is one of the most common physiological transitions in the male lifespan. Here's what makes this silence particularly costly. Erectile dysfunction after 50 is not just a sexual health issue. It is, in many documented cases, one of the earliest warning signs of cardiovascular disease. The same arterial changes that impair blood flow to the heart can first appear as impaired blood flow to the penis, sometimes 3 to 5 years before a cardiac event. Which means that when a urologist or cardiologist evaluates a man for erectile dysfunction, they're not just looking at his sex life. They are looking at a window into his vascular health. And that window tells a story that the rest of his body hasn't revealed yet. To understand why erections change with age, you have to understand how they work in the first place, and most people, including many men, don't actually know. An erection is fundamentally a vascular event. It begins not in the genitals, but in the brain. A signal, whether from a thought, a sensation, or physical touch, travels down through the spinal cord and triggers the release of a molecule called nitric oxide. Nitric oxide is one of the most important compounds in the male sexual response. It acts as a signaling agent that causes the smooth muscle tissue inside the arteries of the penis to relax. When those muscles relax, blood rushes in, filling 2 chambers of spongy tissue called the corpora cavernosa. As those chambers expand, they compress the veins that would normally drain blood away. The result is a firm, sustained erection. This is a process that depends on 3 things functioning simultaneously: healthy nerve signaling, healthy arterial walls, and adequate nitric oxide production. And after 50, all 3 of these systems begin to face challenges, not catastrophic failure, but measurable cumulative change. Testosterone is the hormone most men think about first, and for good reason. Testosterone plays a central role in libido, energy, mood, muscle mass, and indirectly in erectile function. After the age of 30, testosterone levels in men decline by roughly 1 to 2% per year. By 50, many men have lost 20 to 30% of their peak testosterone. By 60, that number can be significantly higher, depending on lifestyle factors, body composition, and genetics. But here is where most conversations about testosterone go wrong. Low testosterone is not always the primary driver of erectile dysfunction. It absolutely contributes to reduced desire and reduced sexual motivation. But the mechanics of an erection, the actual hydraulic process of blood-filling tissue, are driven more by vascular health and nitric oxide availability than by testosterone levels alone. Which is why some men with perfectly normal testosterone still struggle with erectile function, while others with moderately low testosterone do not. The relationship is real, but it is not the whole picture. What does matter enormously is a molecule most men have never heard of: endothelial nitric oxide synthase, or ENOS. This enzyme is produced by the inner lining of blood vessels, and it is responsible for generating the nitric oxide that triggers erectile response. As men age, and especially as cardiovascular risk factors accumulate, high blood pressure, elevated blood sugar, high cholesterol, sedentary behavior, the endothelial cells that produce eNOS become progressively less efficient. Less nitric oxide, less smooth relaxation, less blood flow. The biological result is exactly what men experience clinically. There's a concept in urology called endothelial dysfunction, and it is perhaps the most underappreciated explanation for age-related erectile changes. The endothelium is the single-cell thick lining of every blood vessel in your body. Healthy endothelial cells are constantly producing nitric oxide, regulating inflammation, controlling blood pressure, and managing the flow of blood through your vascular system. When those cells are damaged or functionally impaired by oxidative stress, high glucose, smoking, chronic low-grade inflammation, or simply decades of suboptimal nutrition, they lose their ability to produce adequate nitric oxide on demand. And sexual arousal is one of the highest on-demand moments for nitric oxide production in the male body. The system requires a rapid, robust release of nitric oxide to initiate and sustain an erection. When the endothelium is impaired, that release is sluggish, incomplete, or insufficient. The result is not always complete inability. It might be softer erections, erections that begin but don't sustain, or erections that require significantly more stimulation than they used to. These are textbook signs of endothelial dysfunction, and they are reversible, but only if addressed through the right channels. This brings us to a truth that most men find genuinely surprising. The single most powerful intervention for erectile health after 50 is not a pill, not a hormone, and not a supplement. It is cardiovascular exercise. Study after study, including a landmark meta-analysis from the American Journal of Cardiology, has demonstrated that aerobic exercise significantly improves erectile function in men with mild to moderate erectile dysfunction. The mechanism is direct. Sustained aerobic activity, running, cycling, swimming, brisk walking, stimulates the endothelium to produce more nitric oxide. Over weeks and months of consistent exercise, eNOS expression actually increases. The cells become better at producing the molecule the erection process depends on. Blood pressure drops. Arterial flexibility improves. Body composition shifts in ways that support healthy testosterone levels. Everything that contributes to erectile function improves in parallel. The research suggests that 40 minutes of moderate to vigorous aerobic exercise, performed 4 times per week, can produce measurable improvements in erectile function in as little as 3 months. That is a faster timeline than most men expect, and it requires no prescription, no side effects, and no cost beyond time. Which raises an uncomfortable question: why don't more men know this? Why isn't this the first thing prescribed? The answer has something to do with how we have collectively medicalized this issue. The introduction of PDE5 inhibitors, the class of medication that includes sildenafil and tadalafil, in the late 1990s was genuinely transformative. These medications work by blocking the enzyme that breaks down the signal generated by nitric oxide, effectively extending and amplifying the erectile response. They are safe, effective, and have given millions of men back a quality of life that had diminished. There is no reason to dismiss them. But what they do not do is address the underlying vascular dysfunction that created the problem in the first place. They are, in the most precise sense, symptom management, not root cause resolution. A man who takes a PDE5 inhibitor and experiences restored function has not reversed his endothelial dysfunction. He has temporarily compensated for it. The same arterial changes that impair his sexual function are still present. And in the context of cardiovascular risk, that matters enormously. The most progressive urologists and cardiologists now speak about erectile dysfunction as a sentinel event, a signal worth investigating seriously, not simply medicating. Because in many cases, the man who addresses the underlying vascular dysfunction through lifestyle changes will not only recover better erectile function over time, he will also be reducing his risk of heart attack, stroke, and metabolic disease simultaneously. The sexual health benefit and the cardiovascular benefit are 2 outputs of the same biological improvement. Diet plays a surprisingly direct role in erectile health, and not in the vague, general way that eat healthy advice usually implies. Specific dietary patterns have been studied in relation to erectile function with meaningful results. The Mediterranean diet, characterized by olive oil, fatty fish, legumes, vegetables, whole grains, and minimal processed food, has been associated with lower rates of erectile dysfunction in multiple large observational studies. The likely mechanisms involve reduced systemic inflammation, improved endothelial function, better blood sugar regulation, and higher circulating levels of antioxidants that protect vascular tissue from oxidative damage. The dietary pattern also tends to support healthier testosterone levels by reducing the excess body fat that accelerates testosterone conversion to estrogen. A process called aromatization foods rich in dietary nitrates, like beets, leafy greens, and arugula, provide substrate that the body can convert into nitric oxide through a non-enzymatic pathway, effectively supporting the same molecule that the endothelium produces. This is not a cure, but it is a meaningful contribution to the biological environment that erectile function depends on. Processed sugar and refined carbohydrates, on the other hand, are among the most damaging dietary patterns for vascular health. Chronically elevated blood glucose leads to a process called glycation, where glucose molecules bond to proteins in arterial walls, stiffening them and impairing their ability to dilate. It also drives oxidative stress in endothelial cells, directly impairing nitric oxide production. The connection between type 2 diabetes and erectile dysfunction is so strong that urologists routinely screen sexually active men with ED for prediabetes and insulin resistance, because in many cases, the metabolic condition preceded the sexual complaint by years, silently causing damage before it ever showed up on a routine blood test. Sleep is another variable that doesn't get nearly enough attention in conversations about men's sexual health. The majority of testosterone release in men occurs during deep, slow-wave sleep, specifically during the early cycles of the night. Sleep deprivation, poor sleep quality, and sleep disorders like obstructive sleep apnea directly suppress this nocturnal testosterone release. Studies have shown that just 1 week of sleeping 5 hours per night can reduce testosterone levels in healthy young men by up to 15%. For older men already navigating age-related testosterone decline, poor sleep compounds the problem in a way that no supplement or optimization strategy can fully offset. Sleep apnea, which affects an estimated 30 to 40% of middle-aged men and is significantly underdiagnosed, is a particularly important factor. The repeated oxygen desaturations that occur during apneic episodes cause endothelial damage, increase systemic inflammation, elevate cortisol, and suppress testosterone, a near-perfect storm of mechanisms that collectively impair erectile health. Many men who are successfully treated for sleep apnea, with continuous positive airway pressure therapy or other interventions, report meaningful improvements in both energy and sexual function within weeks. Not because of any targeted sexual treatment, but because the underlying physiological disruption causing both problems has been addressed. Psychological factors deserve more space in this conversation than they typically receive. Erectile dysfunction exists at a crossroads of body and mind, and once a man has experienced difficulty with erections, regardless of the original physical cause, a psychological dimension almost always emerges. The anticipatory anxiety that develops after several experiences of erectile difficulty creates a feedback loop that neuroscientists call spectatoring, a mental process where a man begins to observe and evaluate his own sexual performance rather than being present in the experience. This cognitive pattern activates the sympathetic nervous system, the fight-or-flight response, which is fundamentally antagonistic to the parasympathetic state that erection requires. Adrenaline and cortisol are vasoconstrictors. They reduce blood flow. They narrow arteries. The more anxious a man becomes about his performance, the more he physiologically sabotages the response he is trying to produce. This is not weakness. It is basic neurophysiology. And it explains why many men experience perfectly strong erections during sleep or upon waking, when the psychological pressure is absent, while struggling during partnered activity. The plumbing works. The psychological environment is the variable. Addressing this dimension through open communication with a partner, or through working with a psychologist or sex therapist who specializes in sexual health, can be as effective as any physical intervention, and in many cases, far more lasting. Strength training occupies an important but often misunderstood position in male hormonal health. Resistance exercise, lifting weights using resistance bands, or performing bodyweight training with progressive overload is one of the most evidence-supported ways to support healthy testosterone levels in aging men. Compound movements that engage large muscle groups, such as squats, deadlifts, rows, and presses, produce the most significant hormonal stimulus. The mechanism involves both direct testosterone release in response to heavy muscular effort and the longer-term benefit of increased lean muscle mass, which is associated with healthier hormone profiles. But the timing matters. Overtraining, excessive exercise volume without adequate recovery, actually suppresses testosterone through chronically elevated cortisol. The optimum appears to be 3 to 4 sessions per week of resistance training, with each session focused on compound movements performed at moderate to high intensity. Combined with the aerobic exercise discussed earlier, this creates a comprehensive physical environment that supports every biological system involved in male sexual health. Body composition matters too, and not only aesthetically. Adipose tissue, particularly visceral fat, the type that accumulates around the abdomen, is metabolically active. It produces estrogen. In men, excess visceral fat creates an imbalance between testosterone and estrogen that amplifies the effects of normal age-related testosterone decline. The lower a man's body fat percentage, particularly in the abdominal region, the more favorable his testosterone to estrogen ratio tends to be. Which means that losing body fat, even without any other intervention, can meaningfully shift the hormonal environment in a man's favor. Let's talk about what a conversation with a urologist about erectile health might actually look like, because many men who would benefit from this conversation have never had it. A comprehensive evaluation typically includes a detailed medical and sexual history, blood work assessing total and free testosterone, complete blood count, metabolic panel, lipid profile, and fasting glucose, and often a blood pressure assessment. Depending on the findings, the urologist may also look at prolactin levels, thyroid function, or refer for a sleep study if apnea is suspected. The goal is not simply to prescribe a medication. The goal is to understand what is driving the dysfunction, whether it is predominantly vascular, hormonal, neurological, psychological, or some combination, and to address that root cause. Men who approach this conversation proactively, before symptoms become severe, tend to have the most options and the best outcomes. The men who wait years, out of embarrassment or stoic avoidance, often find that the physiological damage has progressed further than it needed to. There is no shame in this conversation. A urologist discussing erectile health is having the same conversation as a cardiologist discussing coronary artery disease. Both are talking about blood vessels. Both are talking about lifestyle-driven changes that are, in many cases, modifiable. Both are talking about long-term health. There's something worth sitting with as we come toward the end of this. The conversation about erectile health is, at its deepest level, a conversation about how men relate to their bodies and how much they are willing to pay attention. For most of adult life, the male body performs quietly. It doesn't require much conscious maintenance. It handles stress, absorbs bad habits, metabolizes bad food, and keeps moving forward with minimal protest. Until, gradually, it doesn't. And the systems that begin to show wear first are often the most sensitive ones: the vascular system, the hormonal system, the nervous system. Erectile health is, in this sense, a kind of biological report card. Not a judgment and not a permanent verdict, but a signal. A message from the body worth reading carefully rather than suppressing. The men who respond to that signal with curiosity, with action, and with honesty tend to discover something unexpected. That addressing the underlying factors not only improves their sexual health, but also improves their cardiovascular health, their sleep, their energy, their mood, and their long-term longevity in ways that extend far beyond the bedroom. The body is not failing. It is communicating. The question is whether you're listening. If this video opened a door in your thinking about male health, share it with someone who might need this conversation. Leave a comment with what surprised you most. And if you want to go deeper on the science of hormonal health, vascular function, or lifestyle interventions for men over 50, there's more waiting for you right here. Because the more we understand our bodies, honestly, clearly, without embarrassment, the better equipped we are to live in them for a long time.